Hello and welcome to another episode of Physiology with Shakthi. So in today's episode, we are going to understand this graph that is mentioned in Ganongs textbook. There's a different version of this in Guyton as well. So in this graph, we have three types of pressure, two types of pressure that are mentioned over here. We got the intrapleural pressure, we got the intraalveolar pressure, and by the combination of them, there's something called the transpulmonary pressure. And the last graph is the volume change that is there. So when we talk about your airway, I had explained part of it in the previous class. We got the lungs and we got the chest wall. And so we got the lung over here. This is the lungs parenchyma. And over here we got the ribs, and in between the ribs and all over the ribs we got different types of muscles that are involved in respiration. Now between them there is a space. It's not this big as you see over here. It's a 10 to 20 micrometer small space which is present, and that is your pleural space. So we got two types of pleura. Whatever is adherent to the visceral part of the body, the visceral components, the visceral organs. So that is inside. So that is your visceral pleura. It's a thin membrane which is lining your lung parenchyma. And another thin membrane just inside of your chest wall. That is your parietal pleura. So we got the visceral pleura, we got the parietal pleura. It's a very thin space of 10 to 20 micrometer, and between them we got your pleural fluid present. And this pleural fluid makes sure that there is minimum friction between them. So every time the chest has to expand and every time the lungs move inside, there is no friction that is made available. So to reduce that, we got the pleural fluid. So it's a very thin space that is present. Now, how is this pleural fluid produced? We got the parietal pleura, and in the parietal pleura, we got various blood vessels. And from the blood vessels of the parietal pleura, we got ultrafiltrates which are forming, which go into the pleural space and form the pleural fluid. And from here, this visceral pleura, they have lymphatic channels which are present, which ultimately drain them away. So usually around the mediastinal area and the interlobar area, from there the filtrate is drained and it is taken out through the lymphatics. So that is what happens normally. So you understood how pleural fluid is produced from the parietal pleura blood vessels, ultrafiltrate is formed, and finally from the visceral pleura, the lymphatics which are present will drain them away. So that makes sure that excess of pleural fluid is not there. So this is a very small, narrow space, and that is a closed space. So this is a closed space with your pleural fluid which is present inside. Now, this closed space I had explained to you last time out. So in this closed space, your lung parenchyma has a natural tendency to go inside. It's like an elastic bandage. Imagine an elastic bandage. You pulled it and kept it like that. So this, the natural elastic recoil of the lung would want to make it collapse, would want to make it go inside. So that is the natural tendency of your lung parenchyma, to recoil inside. But when we talk about your chest wall, imagine you take the chest wall, you cut out all the muscles that are associated with it and keep it, it expands a bit. So its natural tendency is actually to move a little more outside. That is its natural position. Because of the attachment of your parietal pleura, because of the attachment of the muscles that are involved, it goes a little more inside and gets more crowded than normal. And if you were to remove all that, it would normally want to move outside. So what happened here? There are two forces that are acting. One force is the recoil pressure the recoil force of the lung parenchyma, and the other is the outward force, right, the outward movement of the rib cage. So these are opposing forces which are acting like that, and because they are acting like that, opposing each other and pulling each other apart, this space is enlarged. So I'll explain to you last time about the same thing. So for those who haven't understood this, this is a closed space over here which is being pulled to either direction. And when this is pulled to either direction, because of Boyle's law, because it's a closed space, the volume has increased. But because it is inversely proportional to the pressure drops. So at rest, you inspire, you expire. Normal, tidal, inspiration and expiration. So you inspire, expire. So when you finish expiration, normally the amount of volume that is there inside the lung, that is called the functional residual capacity. So residual volume and the expiratory reserve volume. So that together forms the functional residual capacity. That is the amount of air that is present, volume of air that is present normally at that stage, at the end of normal tidal expiration. So at this point of FRC, that point is when the pressure of the forces, the recoil and the chest wall pressures are equal and opposite. So both of them pull each other on the opposite direction, and it is equal and opposite and keeps it like that. So that point is the resting point, and at that resting point you got equal activity on either side. You got me? So that is what happens at FRC. So this is another question that will come. At FRC, there is equal and opposite forces acting. So what we are talking about over here is the intrapleural pressure. So there is a pressure over here inside the pleural, and that pressure is what we are talking about right now. That is your intrapleural pressure. So at this point, when the equal and opposite forces are acting, and that results in increase in the volume and decrease in the pressure, and that pressure goes to a negative value. And along with that, there is also another reason why it is negative. We got the lymphatic channels I had mentioned earlier. So imagine this closed space, and from this closed space you are further draining things away. So that will further decrease the pressure over here. When you suction things out of already created vacuum sort of space, that will result in a negative pressure. So this kind of work over here will result in your negative intrapleural pressure. So that is why your intrapleural pressure in the normal resting state is negative. So at this point, it is going to be around -5 centimeter of water. So please make a note on the values over here. So the unit is kind of important. So in Guyton's textbook, whether you take a look at Boron's textbook, you find this value given, -5 centimeter of water. And when you take a look at Ganongs' textbook, it is giving a value in millimeter mercury. So that value in millimeter mercury is coming to -2.5 millimeter of mercury in Ganong. But if we actually convert these from here to here, it comes to actually 3.8 if you do the actual conversion. So this is just for you to have an idea, because of this they are not going to ask a question like that based on 2.5 and 3.8. That closer thing won't be present, so you don't have to worry about that. So just know this. If in case you see 2.5 millimeter mercury, that is right. If you see -3.8 millimeter mercury, that is also right, if you do the actual conversion. If you take -5 centimeter of water, if it's in centimeter of water, it is -5. Alright, so this is the resting stage that is present. Now after this, when you inspire, what is happening during inspiration? During inspiration, your diaphragm is going down. Your upper to, remember the pump handle action. So because of that pump handle action is happening, your transverse diameter is also increased by your intercostal muscles. So because of your intercostal muscles, your transverse diameter is also increased. That is the bucket handle movement. So because of all this, what is happening? Further increase in the volume is happening. So further increase in the volume would mean pressure further drops. So this pressure from -5, it goes to minus 7.5 centimeter of water, or the value given in Ganongs, minus 2.5 to minus 6 millimeter of mercury. So you keep a note of both these values over here. So what happened here? When you inspire, because of the increase in the vertical diameter, because of the increase in the anterior posterior diameter, because of the increase in the transverse diameter, ultimately that resulted in more volume and further drop in pressure. So already initially, because of this equal acting forces at FRC, the interpleural pressure is negative. And apart from that, because of the effect of the lymphatic channels, it is negative. So that is why the interpleural pressure starts off to be a negative value, and from that value it further becomes more negative because of the effect of this inspiratory muscles. So that resulted in it going further down. So now let's come to that diagram over there. So at the end of expiration, where inspiration is about to begin, it starts off with a value of minus 5 centimeter of water, or minus 2.5 millimeter of mercury. And from that point, at the end of inspiration, it reaches a value of minus 6 millimeter of mercury, or minus 7.5 centimeter of water. So it reaches over here, and at the end of expiration, again it goes back to your original value. So this is what we get theoretically. So this is what we get theoretically. But when you actually take a measurement of all this, we see that there is a slight skew to this diagram. Instead of it happening like this, there is a skew towards the left side. So it ends up becoming like that. The reason for that is your tissue resistance, the elastic tissue and the viscous resistance which are offered will result in this lag. Now this might result in some students having a question. I have this question: if there is resistance, shouldn't it make things slower? Because of the resistance, shouldn't it make things slower rather than faster like that? So in case you have this doubt, I'll just clear it after some time, after we discuss the next pressure. So you'll have a better idea at that point. This is the intrapleural pressure. Apart from this intrapleural pressure, we got the intraalveolar pressure. So when we talked about the pleura, inside this we got different alveoli which are present. So the pressure inside this alveolar, that is your intraalveolar pressure. So this pressure is the intrapleural pressure. This is your intraalveolar pressure. Now, when you talk about intraalveolar pressure, we got the alveolar over here, and beyond the alveolar, we got the pleura. So this pressure over here in the pleura is the intrapleural pressure. Now we know that intrapleural pressure is a negative pressure. A negative pressure means a suctioning force. And from minus 2.5, when it goes to minus 6, the suctioning force increases. It becomes more negative, means more suctioning. So when there is an alveoli over here and there is a suctioning force that holds the alveolar together like that, and when the suctioning force becomes greater, it pulls it out more. So at this point, what is going to happen? The alveolar again is going to get suction and it is going to become larger inside. So because this gets pulled and it becomes larger, again your Boyle's law comes into play. So the volume increased. So what happens when the volume is increased? The pressure inside drops. The volume increased, the pressure inside drops. So during inspiration, this is what happened. Because it became more negative, the suctioning effect will increase the volume, resulting in a drop in pressure. So over here, inspiration is happening, and during this point, there is more suctioning and there is a drop in the intraalveolar pressure. Okay, so in the second graph, in the y-axis, we're going to denote the intraalveolar pressure. This was the intrapleural pressure over here. Now we're going to denote the intraalveolar pressure. So the outside pressure is known to be 760 millimeter of mercury. Okay, so let's take 760 millimeter of mercury as a zero value over here. And with respect to that, a +1 or -1. So +1 would be 761 and -1 would be 759 millimeter of mercury. So when I mention +1 or -1, that is what I mean. Okay, so over here we'll make the -1 and we'll make the +1. So what happens to the pressure during inspiration? We just realized that the pressure drops. So the pressure finally reaches your -1 value. So what happens over here? This pressure slowly drops to -1. So when it drops to -1, what happens? This is not a closed space like this. It's an open space which has connection to the outside pressure. Now when this drops by -1, so this has become 759. And this pressure outside is 760 millimeter of mercury. And if this is an open space, then what is going to happen next? Based on the pressure gradient from 760 millimeter of mercury, the air is going to enter inside. And you inspire now. So air is entered inside in order to equilibrate this inside pressure with the outside pressure. Ultimately, this pressure goes back to 0. At the end of inspiration. So we are inspiring. At the beginning of inspiration, your inside pressure has dropped to -1. And because of that, air now enters. And towards the end, when there's no movement, net movement of air is not there, what happens? The pressure has been equilibrated. Outside pressure and inside pressure has been equilibrated. And because of that, there is no net movement over there. So that is what happens over here. So initially, because of this negative intrapleural pressure, the pressure drops, and that suctioning force will further result in drop of this pressure. When this pressure drops, that would result in air to come in, and that air coming in equilibrates it back to the normal pressure. So because of this, what happens to the volume? So let's say this graph over here is for the volume. So because we are talking about tidal ventilation, I'll just give a value of 0 to say 0.5 liter or 500 milliliter. So this pressure volume over here by this point to equilibrate that air entered. So that amount of air, the volume that entered is, so that is what happened. Because of this, this happened. Because of this, this happens. And ultimately your tidal volume of 0.5 liter has entered inside. Are we clear here? Yes. So at this point, your inspiration has ended. Now when we talk about expiration, it's kind of the opposite. When we talk about expiration, this negative pressure is no longer there. The passive recoil of diaphragm is there, which pushes this further inside. So this pushes it. When forceful expiration is there, the internal intercostal is acting and reducing the chest wall diameter. Along with that, diaphragm is also acting. Along with that, abdominal muscles are acting. So in every way, this pressure becomes less negative. And see over here, even goes more less than the value at rest. So that is what happens. So ultimately that will result in this going inside more rather than expanding. This would be comparatively relatively more inside now. So this pressure, inside pressure now, would result in this volume going inside. So when volume decreases, what happens to the pressure? Pressure increases. So this pressure is now, instead of -1, it is now going to +1. So in a similar fashion, this is going to go to +1. And because it goes to +1, this pressure would go to 761. Now the inside pressure 761, outside pressure 760, which should mean the normal movement of air would be outside. And finally, because of this movement, this gets equilibrated back to your normal level. And because of this, when air is moving out, this much volume of air is again coming out. So this is your tidal volume. So if we put a spirogram over there and you measure it. So with a spirometer, when we measure this expired air is what we measure. Got it? So you understood how easy this whole graph is. So this is the intrapleural pressure, this is the intraalveolar pressure, and this is the final volume because of that. And this is how respiration happens. This change in intrapleural pressure results in a change in intraalveolar pressure, and that would result in ultimate volume change. Got it? So this is how these pressures can be explained, and that is the importance of all these pressures in understanding how respiration works. So let's just go back to that previous question we had in mind. We told that because of resistance, this is queuing to the left. The question was, usually when there is a resistance, doesn't it slow the process rather than make it faster? So in this case, we just have to think about it in a different way, from a different perspective. So take a look at this. This happens over here. It goes to -1, right? So from this point, let's extrapolate it over here to the first one. What does it mean? This pressure that you see over here, this much amount of pressure is needed. This much amount of negative pressure is needed to result in this change. Yes. Now, let's look at the actual diagram. This is the theoretical value. In the actual diagram, this much amount of pressure was actually needed to make that change at that point. So do you see that there is a greater amount of negative pressure that is needed to make the same amount of change? So that is basically what happens. That is because of the resistance. Because of the resistance over here in this movement of the lung parenchyma and things like that, because of that resistance offered, you need more pressure. More pressure is needed in order to make the same change. So that is actually why this has got skewed. Let's talk about expiration. See what happened? You need less negative values here to make it expire, to push it more rather than this. So that is why ultimately this resulted in a skew to the left. So now that we understood this, we got to understand terms like transmural pressure, transpulmonary pressure, which have been used interchangeably and which might confuse students. And it comes in questions like that as well. So let's take a look at how transpulmonary pressure and transmural pressure are different and what they are actually. So first let's get the concept of transmural pressure in the way. Transmural, mural refers to a wall. So the wall of a body cavity, that is mural. So transmural, so the radial pressure across the wall. So when we take anything like this, a cavity or something, and over here in this example, this is a tracheobronchial tree. Anywhere along the tracheobronchial tree, this radial pressure across the wall, that radial pressure across the wall anywhere along the tracheobronchial tree is what is called the transmural pressure. when you take a transmural pressure at the level of your alveoli. So this is the alveoli, and outside here we actually got the parenchyma, lung parenchyma over here, and beyond it we got the pleural pressure. This is where we got the pleura, and beyond it we got the chest wall. So this pressure over here, this pressure that is coming here, that is your transmural pressure at this level, and this transmural pressure at the level of your alveoli, across the alveoli, the lung parenchyma, and your intrapleural layer. So this is what is called the transpulmonary pressure. Alright, so we got the transmural pressure anywhere along the tracheobronchial tree, a radial pressure across the wall, that is your transmural pressure. And transpulmonary pressure is a transmural pressure at the level of the alveoli. So normally, as I had mentioned, your lung has a capacity to recoil, what is called the recoil pressure. So normal tendency of it is to go inside, shrink inside. This transpulmonary pressure, in other words, can be represented by a force that is acting to prevent the recoil. So this is acting in a direction opposite this. So this is something that is trying to oppose your recoil pressure. So we got two pressures that we had mentioned earlier. We have the intraalveolar pressure and we got the intrapleural pressure. So imagine this intraalveolar pressure. What direction is it? This pressure is like this outside. So this is contributing to this. Yes. So this transpulmonary pressure equal to intraalveolar pressure, and when we talk about the intrapleural pressure, so let's take it as a positive pressure. This positive pressure would exert a pressure like this. Is it aiding in this, or is it aiding the recoil pressure? It's aiding the recoil pressure. So ultimately this total pressure would be this pressure subtracted by how much is opposed by this. That is why in the formula we get it as intraalveolar pressure minus your intrapleural pressure. But we know that this is not usually opposing because it is a negative pressure. So a negative pressure is actually suctioning it and adding to it. That is why negative of negative would result in a positive value. So even that is included here in order to oppose the recoil pressure. So we got the alveolar pressure, we got the pleural pressure, right? This is positive and this is negative. A negative of negative means ultimately it helps in opposing your recoil pressure. So now you understood why this formula came to like this. Yes, so that is your transpulmonary pressure, and you know what your transmural pressure is. Now that we understood this concept and understood what pulmonary pressure is, there is some concept called the equal pressure point. So that is especially important when you talk about dynamic obstruction and all that. So I've seen questions being asked on this. So I'll just mention this also. Alright. So in this whole scenario, we got the alveoli and the terminal bronchioles, and finally over here we got the bronchi, and over here the end stage of the bronchi we got cartilaginous layers which are not present over here. So this is some sort of support over here, and we got the intrapleural pressure. So when we inspire, this value is negative, so this pulls it outside. This intrapleural pressure is actually not only over here. This pleura is covering the entire lungs. So So this pressure somewhat kind of is acting all over. There are many alveoli like this, but ultimately this pressure outside is going to suction the entire thing. So during inspiration, it is going to pull this, it is going to pull this, and it will keep the airways patent because it is a negative pressure. But what about expiration? So normal expiration is still passive expiration, it is still kind of in the negative values. It doesn't go positive much. We've seen the diagram earlier where it goes back to minus 2.5 millimeter of mercury. But when you forcefully expire, it can go up till plus 30 millimeter of mercury. When you forcefully inspire, this can go up till minus 30 millimeter of mercury. So normally this is minus 2.5 millimeter of mercury. From this, it can go till minus 30 millimeter of mercury when you inspire forcefully, maximum inspiration. When we try to expire, normally from minus 6, it goes to minus 2.5. So normal inspiration, expiration, minus 2.5 to minus 6, and it comes back here. But forceful inspiration, it can go up till minus 30. Forceful expiration, this can even go till plus 30 millimeter of mercury. So imagine a value of plus 30, which is pressing upon this, 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 everywhere. Now in this scenario, over here, say this has come to plus 38. The intraalveolar pressure is being pushed and there is some alveolar pressure already. So both of them together will come to plus 38. Now this intrapleural pressure, this intraalveolar pressure, so this pressure needs to be equilibrated with outside. So it moves out now. But as it moves out, this pressure, this is more narrow airway, and some sort of resistance will also be there, and ultimately in different areas this pressure is going to drop slowly. So some point it will be plus 30 here. So what happens over here? This is kept open. Over here this is plus 30, over here this is also plus 30. So these are equal pressure points, where inside is plus 30, outside is plus 30, nothing happens. It still remains patent. And it decreases slightly, say plus 18 and plus 15. So at this point, when the outside intrapleural pressure is enough to collapse this. But that sort of drop usually happens in the much more proximal bronchi. Normally, I'm talking about normal scenario, normal people. So that area is usually supported by your cartilaginous tissue. So it does not collapse. But over here now some degree of narrowing is there. So that is why during expiration, you have to understand that expiration is slower. When you expire forcefully, initial area is fast. Because of all this pressure that is coming out, initially it is very fast. But after some point, this slight collapse starts happening. This pressure, intrapleural pressure, is still going to be plus 30. It is slightly going to result in some narrowing, and that makes sure that your residual volume stays. It's not simply there for a reason like that. You don't want all the air in the lungs to go out. What will happen if it goes out? Because of the action of the surfactants, something that collapses once is very difficult to open up again. So you don't want that sort of a situation right now. That's why you always need some sort of residual volume in the lung. And to make sure that happens, usually during expiration some amount of collapse is happening. And apart from the initial part, your expiration is slowed down. The flow of expiration, flow rate is slowed down. Understood? So this is a normal individuals. Now let's take a look at people who have some sort of obstructive disorders, where some sort of dynamic compression is going to take place. Dynamic. So during inspiration, nothing happens. During inspiration, I had said this is, say, I'm taking maximum inspiration. This is going to be minus 30, this is going to be minus 30, this is going to be pulled, this is going to be pulled, right? So there is no obstruction for these individuals, right? So there is no obstruction over here in this individual because it is going to get pulled. Now this person is trying to expire, right? So in this individual, there is some sort of obstruction already, like he has some disorder, like he has emphysema, right, COPD, or he has asthma. So some sort of obstruction is already there. So this obstruction which is already there, during inspiration it won't be affected much because this is getting pulled. But during expiration, what happens, instead of this coming much more distally, now because of the obstruction, flow rate is reduced and this starts happening much earlier. That equal pressure point I had told you over here and all, it's usually plus 30 and it is an equal pressure point. Instead of it happening there, now this pressure has dropped much more over here. So what is going to happen? Already there is a obstruction, some sort of obstruction, and on top of that, this equal pressure point is no longer there, and this drop in pressure happens much more proximally, much more distally, right? So because this, now this is further compressed during expiration. So this person during inspiration has no problem, but when he's trying to expire, he has an obstruction which is further complicated and worsened, and he finds it difficult to expire the whole volume out. That is your obstructive disorders. So in obstructive disorders, where some sort of dynamic compression, see, it's dynamic because during inspiration it's not happening, otherwise it's not happening, but during expiration, because of this, it is happening. Are we clear with that? That is the importance of understanding this concept of equal pressure point and all this. Alright? So now that we're done with this, in the next episode, we'll take a look at different volumes that are there. The static and the dynamic volumes. If you found this class to be useful, please do subscribe, recommend it to your friends and share it to them so that they also can study properly. So, thank you.